Before we get into the guidelines, let's clarify one more thing. The principal diagnosis and the admitting diagnosis are not the same. The admitting diagnosis is the reason the patient presented for care and why they need to be admitted immediately. For example, they have intractable headaches, nausea, vomiting, and vertigo, or they have bloody stools and hypotension. We might not yet know why the patient experiences these symptoms, but they need care for them right now. These are admitting diagnoses. Principal diagnoses are conditions established after study to be chiefly responsible for the occasioning of the admission. Or in other words, what was the underlying disease what caused such serious symptoms to the patient that they needed hospital care? Having a headache, nausea, vomiting, and vertigo are bad enough, but if there was something else lurking in the shadows, and we found that after studying and treating the patient, that will become our principal diagnosis. Sometimes there is correlation between the admitting and principal diagnoses, other times there isn't. For example, a patient admitted with melena and hypotension can have a gastrointestinal final diagnosis of gastric ulcer, while this other patient arrived with shoulder and back pain and ended up with a diagnosis of an ovarian cyst. Her symptoms were from the musculoskeletal system, but the principal diagnosis is from elsewhere. This is perfectly normal and beautifully demonstrates the difference between admitting diagnoses and principal diagnoses. Alright, now let's get started on section 2 and have a detailed look at the guidelines.